of bypasses, we're taking a dive, as you see here by the slide. Although I was one of the first and the most exciting vascular surgeons that embraced endovascular procedure, I believe that that's probably the first false aneurysm of a fem popliteal bypass that I was able to do endovascular by creating an endograft with 2 stents that I built and a graft. And also a popliteal aneurysm. Unfortunately, not published this, but I think they were the first cases done with endovascular procedures. I did not believe them, that they would work, but they actually worked for at least a year. So, despite that, however, endovascular procedures do fail, as we discuss here, and some of our colleagues in cardiology, at least in the United States, tend to be a bit more liberal in performing indicating an amputation because they said there's no other procedure that's possible to do. They attempt 3, 4, 5 times endovascular and then they give up. And when autogenous veins were absent, many vascular surgeons in my time also were doing amputations. They said, using prosthetics does not work, I'm not going to go to this path. When the runoff was disadvantaged, and often they did not see the runoff because the angiograms were not precise as they are today, and they did not have CTAs, they were doing amputations right and left. And the arteries also were very heavily calcified. I remember my professor said, we're going to do an amputation because there's nothing you can do in these badly calcified vessels. So we go back to Dr. Conlan that described the first femoral popliteal bypass and the concept of a bypass. And this was very attractive to many people, and they jumped on it, although Leriche himself, René Leriche, wasn't happy about that. He thought that this was really a bad idea, and when he went on vacation, because it was Conlan's boss, but he went to a trip in Europe for 3 months, and then Conlan did his bypasses, and they were successful. Well, it took us 40 years from Conlan to really be able to do this plantar artery bypass, and I never realized why people are not doing that artery. It looks pretty good to me. You know, sometimes, as you see here on the bottom right, left, you see this was the first plantar artery, lateral plantar, that we're able to do at the time. And on your right, on your left, you have the medial artery, medial plantar artery that was also very successful. And all it took is a small incision and to open the flexor retinaculum, and the artery was right there by bifurcation. So we were able to do not only this, but also go down to the pedal arch itself, which was not so hard, by retracting the extensor of the first toe and taking part of the second metatarsal bone, we were able to expose the arch itself and do a bypass to it when it was patent. And on the lower picture, on your right, on your left, I'm sorry, you can see that there is a very tiny vessel. This is the lateral dorsal branch, which is the branch of dorsalis pedis, that also was able to do a bypass to. All these bypasses were done with veins. This one here on your right, bottom right, is the bypass to the pedal artery, and this is a bypass that Frank Reed did and successfully, and lasted for a few years before it occluded. And when occluded, the foot was still, the wound had healed, and the patient remained salvageable. The foot remained salvageable. One trick that I learned, if we're going to use those branches in the foot, you have to go with the tip of the bypass into the branch itself and not keeping the parent artery, even when the parent artery is patent for a couple of centimeters, because it creates a lot of turbulence and it causes thrombosis. But when you place the graft right into the tip of into the branch itself, they work significantly better. So, how to get these bypasses to work very well? You have to have a lot of experience with infrapopliteal bypass. That should not be your first case. And you need to use veins, preferentially short veins. We have shown, at least in our own data, that short veins do much better in diabetic patients than long veins, from the common femoral all the way down to the plantar artery. They're not as good as when it's from the popliteal or even the tibial as an inflow. And the other thing that we also learned, that everybody agrees, that you need to have a good autogenous vein, because a bad autogenous vein is worse than anything else. So we obtained 81%. 16 years later, for a group to actually reproduce this and do the plantar artery bypass, because at the time people thought we were crazy to do this bypass of the foot. They said we should create some special shoes for patients. Actually, they didn't have to do that. So 16 years later, the group from Boston, another Montpellier guy, guidance, limb salvage results up close to 70%. In fact, it's overall. But what the problem is what happens if you don't have an autogenous vein. And that's the key thing. Now again, today we're going to do vascular. Let's say vascular is also failed, it's not possible. It showed that veins are significantly better than PGFE, and people took this low percent PGFE results that we have published, and actually this was the first prospective randomized study in vascular surgery done, and it shows that only 12% they said, I'm not going to do this, I'm just going to amputate the leg. However, other people did, as I mentioned yesterday, we work on adjunctive techniques. This Dr. Sigmund used to be a general surgeon in my hospital, and he did vascular surgery, a little bit of vascular surgery on the side. I didn't know that he had actually described the Miller cuff 10 years before Miller even did his first case. He's still considered Miller cuff because he wrote a series, but Sigmund is the one who described this technique of putting a cuff in between the PGFE and the artery, and he also obtained acceptable results. Herb Dardick came with the concept of doing an adjunctive AV fistula at the distal anastomosis to increase the flow to the graft, the prosthetic graft, to allow for increased patency. And these results were equally good. Now, the concept of AV fistula had a lot of issues at the time. There was steel phenomena, and there's a lot of issues. So a friend of mine, Dr. Lee Moran, he actually was the first physician that came out of in a spaceship, out of space, to fix a robotic limb in a spaceship. He's the first physician, a very smart guy, and him and I worked on this patent technique that we developed just by integrating both sides of the equation of Ohm's law. We're able to develop this little system that required a little computer that cost $80 to perform, hooked to the data scope, and then I could measure the resistance through the graft by injecting 20 cc's of saline through the proximal end of the graft. For PGFE bypasses, all the grafts that had a resistance above 1.2 thrombosed within 3 months. All the ones that didn't have a resistance system remained for 3 months. When you got all our experience with veins including, it shows that the lower resistant quartiles, A and B, the patency results and the limb salvage results were much better. As a matter of fact, the worst quartile, the highest resistance quartile, they had 0% limb salvage at 1 year. So I think there was something there, at least hinting to me that increasing resistance was a cause of graft failure for PGF, for prosthetic grafts. So I thought that the concept of fistula was acceptable, but I still was bothered with the fistula, with the patch idea that Dr. Sigmund came, the cuff. So what I did is, I took the best segment of a deep vein adjacent to the artery, I transected it distally to the arteriotomy, and I moved the artery, the vein into the artery, as you see here. It's pretty self-explanatory. And then in the middle figure, you can see I made a epidotomy onto the anastomosis so I don't miss any of the valves, and then I plugged the PGFE. But I also measured the pressure distally, and if it was less than 100 millimeters of mercury, I bended the vein to prevent it from enlarging and also from stealing and actually improving the flow into the foot. I'm going to show you a quick video, and here's a patient who had a limited runoff with isolated segments in the foot. I chose, of course, the best segment of our artery, but with ultrasound before. We transect the vein, transpose it into the artery, and here we're just doing the anastomosis of the artery, the central portion of the artery, of the vein to the artery, and now I'm opening onto the anastomosis and extending it for about 1.5 centimeters and hooking the PGFE bypass to it now. So now we have a cuff and a fistula at the same time. And then if the pressures are low, I put a little band around the vein. Okay, so the patency results were acceptable in 3 years. Remember, those are patients who didn't have any other option. And the limb salvage results were actually an acceptable 73% with this kind of advantage, adjunctive AV fistula. Now, these operations are all redo operations. They had had multiple previous operations, and they were at the end of the line. So to minimize the time that I spend doing these redo operations, I suggest that we go in a virginal area to the external iliac artery by making 2 small incisions, one above the inguinal ligament and the other one in the medial medial aspect of the sartorius muscle, and then we make a tunnel, manual tunnel, lateral to the artery and the vein so we don't cause any damage. And in about basically 2 minutes, you can identify and isolate a very virginal area for the inflow. So, does the inflow from the external differ from the one from the common femoral? It really doesn't. We obtained the same results with 112 cases, divided between the iliac inflow and the femoral inflow are basically the same. So I think rather than doing redo operations, spending extra 2 hours, and having an 8 times more chance of complications, it's better to go to a virginal area, and it's much easier and faster. Now, you won't believe it, but in the 80s, I just happened that I did the first deep arterialization of the distal venous system when I didn't have anything to offer to the patient. No autogenous conduit, no deep veins, the limited runoff. So I basically took a bunch of patients and I cut the valves in the saphenous vein distally, and I did bypass the saphenous vein. And some others I did to the deep veins where I cut the valves as well under direct vision, antegrade, and I was able to revascularize the case in some patients. Some did not work, but some other worked. And here I call the one with the superficial one, I call the saphenous turn down epifistula, where you dissect the distal saphenous vein at the ankle, ablate the valves distally, and make a slight curve subcutaneously, and anastomose it to the recipient artery at the level of the plantar or the distal popliteal, or even the dorsalis pedis. So, and then after this, you place a PTFE all the way at the end. It's computerized. I'm not sure. But it shows down in the lower bottom. And this is what the angiogram, completion angiogram showed. Now, let's talk about the 80s now, when we did this. The reason I did not pursue it aggressively, because some of these patients did not do well after a few months. And they healed the wounds, but it took a long, long time to heal the wounds. So I learned also not to do early amputation when something fails, because sometimes the wound heals on its own. So be patient for some of these cases. The other thing that I learned also, that you can do actual transposition of infrapopliteal vessel. Here's this patient who had absolutely zero options. He had an isolated anterior tibia and dorsalis pedis, which was occluded distally, and an ischemic toe, pregangrenous. So I did, but everything was good down to the peroneal. So through a 1 single incision, the lateral aspect of the lower leg, for about 15 centimeters actually, 10-15 centimeters, I took part of the fibula. I isolated the anterior tibial and the peroneal, and from the same incision, and then I transposed, as you see here, in the bottom down on your right, the anterior tibial onto the peroneal artery. This transposition worked for 6 years, and then they allowed to follow up with the patient. But the foot, was totally south. Now, I also realized that some of the trauma patients that I did over the years, that I was doing bypasses and the bypass would fail, despite doing a fasciotomy on the leg, they were acute ischemia. I realized that I had to do something extra, that the leg fasciotomy was not enough. So by taking the extensor retinaculum in the ankle, and also doing a plantar fasciotomy, I lowered the pressure in the foot, because in these 11 patients, when I described this in the Journal of Vascular Surgery, back in the 80s, the pressure was high. It was over 60, 70 millimeters of mercury in the compartment of the foot. So I did a fasciotomy, and then the thrombectomy of the graft worked very well after we did this. So don't forget that fasciotomy in the leg sometimes is not enough for this patient. It's a good idea to measure the compartment of the foot. All right, the real nightmare of vascular surgery, of course, is calcification. So I did learn from my mentor, Dr. Pete, that cracking the vessel in 2-3 millimeters intervals actually allows you for clamping and opening the vessel, and sometimes placing sutures. And if you open the vessel and you have a little flap, tack down the flap, and the artery is going to behave like it is not calcified. What I did, in addition to this technique, is use a Rensure to cut the calcium if I have to, and I do that from the aorta down to the little vessels, and use a towel clip to make a hole into the vessel to allow for the suture placement. And once you get comfortable with this, you can see that it becomes almost a routine part of your procedure. And here you see a little video showing how calcified this vessel is. So now we're using the technique that Frank showed me by clamping the vessel at 2-3 millimeter intervals. And then once I place the clamp, I don't touch it. I place the clamp proximally and distally, and it stays there. Okay, next. Okay. And now, once you open, and I have a lot of calcium on the wall, I use this wrench-or, and of course for a larger vessel, I use a larger wrench-or. And remove the calcium. The important thing is to have a lumen. If you have a lumen, everything's going to work in this situation. Okay, we showed enough of this, and now I'm placing. Can I show the last video? Just showing the last video. And then here you see, replacing the suture. I have to have a good lumen distally. Once this is done, I'm fine with this. Okay, and this is the bypass with the fistula. And here is the patient came with severe ischemia, gangrene, infection, all that. End up after a pedo bypass, all the way down, successfully healed. I'm going to stop here. Thank you so much. Thank you very much.